There's a lot of expectation, and I don't really see the outcomes that you're expecting. Like robotics, people think that if a lot of surgeries are being done with robots right now, not just orthopedics. Orthopedics is coming along that way, but there's a certain way I'm doing, say, a knee replacement right now that significantly surpasses robotics in the way that it's done, because I measure to the 0.5 millimeter and make adjustments based on a 0.5 millimeter, and the robots tend to be around 2 millimeters, so there's a different variance right there.
Hey everybody, welcome back to Mike and the Doc. I'm Mike.
And I'm the Doc, and as you know, I have 20 years of experience, but we have Dr. John Baldauf with 30 years of experience in orthopedic surgery. Welcome, Dr. Baldauf.
Thanks, glad to be here. Appreciate it.
So Dr. Baldauf, for anybody that doesn't know what an orthopedic surgeon does, tell us.
It's about the coolest job for me. Everybody's got different preferences, but basically anything bone and joint, so it's pretty varied. It can be anything from spine surgery, predominantly surgery. There are some non-operative orthopedists, but anything bone and joint, joint replacement, spine, shoulder, foot and ankle, pediatric orthopedics, which is anything, all the above, but in pediatrics. Elbow, shoulder, like I said, trauma. There's 10 or 11 different specialties. You can be in tumor, but anything bone and joint, basically.
Very nice.
And Dr. Baldauf, are you in a particular type of orthopedic surgeon, or do you do it all?
And me particularly, I did not do a fellowship being a year of, at least a year of training after your residency, but I did 9 years of fellowship with the Air Force, but which was in general orthopedics, not a true fellowship, just the time spent. But I specialize in hip, knee, and shoulder replacement. Pretty heavy in that.
Pretty heavy trauma too, right? In the Air Force?
Well, it wasn't. It depends on where you get located.
Oh, okay.
Like I was in one rotation deployed with the Air Force where I was hardly doing anything. I did 6 surgeries in 6 months because everyone was getting diverted.
Wow.
But the person who replaced me went into Baghdad, and that was pretty heavy amputations, and depends on where you go.
Okay, and the
what
time.
you do.
Okay.
Yeah.
Okay.
Now, Dr. Baldauf, he's very dear to me. He's known me for, I think, probably 15 years.
Wow.
Back to when I was a high-flying salesman, pulling at his coattails. Just want to express some gratitude for those 15 years. And he was the first doctor to take the torch at Connolly Care.
Oh,
and both of you guys are on the Connolly Care team, so good to see the team tonight.
Yeah, it's fun.
Yeah, he got me on board by throwing the Arizona card. We both went to the same college, so he threw that out there. And
I remember the basketball game well. He was going to say no because I said, hey, let's go to a game.
Yeah.
And he said, I don't think I'm going to go at the last second. And I said, but we're Wildcats. And he said, well, if you put it that way, I guess I'll go. And here we go 15 years later.
that's right.
So there's a lot of misconceptions about like bone doc. Like like you said, you're a surgeon. I have no idea what a non-operative orthopedic doc does. Tell me what that looks like. Is that like sports medicine or what is
Potentially, yeah. It could be a variety of aspects. So say, it could be a variety of reasons too. So someone may not be particularly, I wouldn't say good in the OR, but they may have developed an issue where they can't operate in the OR, so they can, or they have a different interest that isn't operative, and their specialty may be sports. It might be seeing patients in a tumor field, assisting and taking care of patients in a non-operative capacity.
Okay.
There's not a ton of them around, but they're good to come across because they can obviously produce and be productive.
Cool. So I got that wrong. What do you find like out there amongst like say non-medical people? What do people most commonly get wrong or misconstrue about ortho and what they do?
They're always confusing us with
Orthodontists?
Yep.
Really?
That's funny.
Wow.
I can
And
tell you whose bill will be higher.
podiatrists. We get that
Oh, you get
every once in a while.
Because sometimes ortho does foot too, right?
Oh, yeah.
I actually did a year of prelim surgery, and I know it's super tough. And I know you trained before me when it wasn't residency for I won't say because I can't say that on TV. But I know that you did residency and fellowship a while ago, and I know it's super tough. And what I remember leaving surgery is that there is no life. And how do you balance your life? You know, whenever something happens, you got to be there immediately, I'm assuming. I mean, if it's, I don't know about like a broken kneecap or a broken bone, any sort of pelvic fracture that's bleeding acutely, you probably got to address right away. How do you balance your work life?
It goes down to selection to start with. So someone out of the gates decides they want to do trauma, they've selected their pathway right there and what they're subjecting themselves to, just like if you go into OBGYN, you know what you're dealing with. I started out doing general orthopedics, and there was a lot of call, and you'd have to deal with a lot of late-night issues. But honestly, there's a lot of amazing ER docs, and they can handle quite a bit, and it makes our lives quite a bit easier. So not a lot do we have to go into at night. If they can't reduce a dislocated shoulder or dislocated hip, which doesn't happen too often, but open fractures or something we have to go in for, and something of that nature. But honestly, it doesn't happen that often. There's different levels of trauma centers too. So pick your battles and go where, you know, what you're trying to build. You want to pick what you want to be involved with.
And before we move on, Dr. Baldauf, you were mentioning before we started filming the podcast that you had kind of decided to get your life back and start working less. So since we're on the topic of the work-life balance, like how did you go about making that happen and kind of step away from your work a little bit more to enjoy your life? Did you switch practices, or was it just like, do you own your own practice, or?
No, I'm in the biggest group in town, which there's, I think, 29 of us now. But and we're all, if you want to think of it, independent practitioners within a large group. So we can do whatever we are willing to do and trained to do. But no, what happened with me was I had kids, and I didn't just want to work all the time. So I changed things through the years and tried different things. If my kids had vacation, I would take vacation. And then I started just taking every Friday off. And then my brother is a home physical therapist, and I spoke about the fact of working while we were young and kind of semi-retiring while we were young, so that he, as a home therapist, he saw people that would work, retire, and one of them within 6 months would die, and their whole plan was out the window. So what we decided to do was take weekends, and so for probably the last 10, 15 years, I'll take a 3-day weekend, 4-day weekend, and currently I take one 3-day weekend, one 4-day weekend each month, and I travel to Florida twice a month and go fishing in Florida or something of that nature. So just, it gives me a good reset so that I can come back and work and enjoy work, and I love what I do. I can't see retiring because I love what I do, but at the same time, I'm still playing. I'm not waiting for the future. I'm trying to do stuff now.
And before that, you were doing the 3-day weekend, so it's got to be 10 to 15 years of work-life balance.
Southwest Airlines loves me.
Buddy pass.
That helps.
Okay, so Dr. Baldauf, robotics, 3D printing, and biologics are rapidly changing your field. Which innovations excite you most, and which do you think may be overhyped?
I currently think all of them are a little bit overhyped because people hype something they can make some money off of. But I like to think or like to say to patients that there's a lot of, everyone's got to try and find an angle. Everyone's trying to make a living, so there's a lot of promotion for things that might be more expectation than they are producing. All of them have got some great aspects. I've done some of the robotics, used some of the 3Ds, and definitely used biologics, and they're all beneficial in their various ways, and not all of them really produce. I don't know if you see that as well, but there's a lot of expectation, and I don't really see the outcomes that you're expecting. Like robotics, people think that if a surgery, a lot of surgeries are being done with robots right now, not just orthopedics. Orthopedics is coming along that way, but there's a certain way I'm doing, say, a knee replacement right now that significantly surpasses robotics in the way that it's done, because I measure to the 0.5 millimeter and make adjustments based on a 0.5 millimeter, and the robots tend to be around 2 millimeters, so there's a different variance right there. So there's an expectation from a lot of people that what is new and latest may be better, but it's not always the case. We're heading that way. And some of the general surgery robots and some of the urology robots, what have you, are fantastic. But in orthopedics, it's there's still a lot of growth there.
How long before we see a Dr. Baldauf robot in
It's
the
not
surgery
happening.
room?
I love what I do, and I love what I do with my hands. And it's just, to me, it feels like you're taking some of the artistry out of it, honestly. And I think there's little adjustments, even that there's little things that happen, like you do a robot and it gets real sensitive about a vibration and shuts down. You have to back up. And to me, time is an important thing in surgery. I don't like to see someone whose wound is open for a long period of time. I think it increases the chance for infection if you have an open wound. We have all these amazing infection prevention aspects that we are involved with, but a wound that's open 2 hours as opposed to one that's open a half hour, I think it's a bigger exposure for an infection. So if you have to put these pins in for the robot, or if you have to do this manipulation for the robot, or the robot has a different problem, it commonly, especially when you're getting started with them, they take quite a bit longer. If you're well experienced with them, they can be more efficient and not as cumbersome. And some of the 3D stuff is very good too, because a lot of that is preoperative planning. They do three-dimensional models and targeting devices and what have you, and that can help expedite a surgery and is very specific to a patient. That can be good. And then the biologics are a totally different animal and can help things heal faster and can definitely add a different dimension to what we can do. But not all of them always produce what you're expecting them to. And some are pretty pricey too.
Dr. Baldauf, can you explain what biologics are in a little bit more depth?
Biologics are pretty much anything you're going that's it's going to be ingredients, if you will, if you want to put it that way, simplistic way to help with healing factors or growth or development or for instance, a synthetic bone graft that can help heal a defect, or a tissue that can help a tendon heal or regenerate, or reconstruct a ligament or anything of that aspect.
And where do they get the tissues and the bone pieces from? Is it like stem cells? Are they growing them, or?
That's one of them. They can be grown. There's different aspects. There's they can be from different animals, such as we have pig donors, human donors. Some of them are, and pigs are very similar to humans as far as the tissues. So we've used those for years, porcine grafts. And then stem cells and stuff like that. So it's a big field, a lot of different variety in that.
How are I actually was going to ask about stem cells. How's that? Like, do you put that in the same category as biologics?
It's in there, but talking to the wrong guy about that. I'm not a big fan of that. My comment earlier was I feel like there's a lot of snake oil out there. Stem cells haven't been. I haven't seen the results that I would like to see. Some people swear by them. Joe Rogan,
Right.
a smaller podcast guy, but
Maybe we'll have him on.
but he
If he's lucky.
Are we 1/1,000,000th of him?
he speaks highly of it.
Yeah.
But I think they're so expensive that some people have an expectation. But if you really compare them to placebo, it's hard to see much of a result from them. At least that's my experience. And we were using them for a while, and the FDA is not in favor of them. So we haven't been promoting them in our business. None of us are. And I'll occasionally see people who will say they've had good results with them. I just had one today that said her sister had a fantastic result with it, and there's others that say they had nothing with it. but I'll get that from anti-inflammatories, or I'll get that from, and I've got a funny saying in my office that I'll tell someone, I don't care if you slap a peanut butter and jelly sandwich against your elbow. If it makes your elbow feel better, do it.
Yeah.
It doesn't really matter. So,
You talk about that a lot, Ali. You talk about the
Placebo.
importance of placebo and how they can really help.
You know, yeah, like when I started, I was like, oh, it's placebo. This person's an idiot. But I'm more like into like, holy smokes, I can actually think, this is going to sound really corny, but I can actually think it better. And I guess like from a physiology standpoint, you're doing something with your brain or secreting something that is causing it to feel better. I mean, sometimes placebo is just placebo, but I love the placebo effect. I mean, assuming it can go on. Yeah, I actually, I had a question about your guys, and I don't know what your like number is, but like the guys who've done well with stem cells, are they usually the guys who have little disease to start with? Because like, I mean, if the bone is straight up fractured, you're not doing all these things. You're like you gotta put some hardware in there. But I'm talking about the guys. So what I'm saying, or my assumption, is that the guys have a lot of disease. Those guys don't do as well with the stem cells as the guys who have little disease, or is that totally off?
it's probably pretty varied. I don't know if I can think of a study that's specifically like that, but you would tend to think that someone has less of a hurdle is going to have a better result. But I mean, it's so varied. Can be tendinopathy, there can be arthritis, there can be multi-level degenerative change of the spine. There can be, so it's such a varied spectrum.
Yeah.
But I think if someone's motivated about it and has an open mind, I think there's a huge benefit to mental power, like you're commenting on. Not saying that that's what stem cells are. It's basically, in our business, it boils down to inflammation reduction.
Right.
Doesn't matter what it is, whether it's ice or stem cells, or it's pretty much what we do is inflammation reduction. That decreases pain and increases function, and however you get there. Peanut butter and jelly sandwich.
Inflammation, bro. It's everything. It's everything.
Just out of curiosity, is that what stem cells are meant to do, is reduce inflammation?
Promote healing.
Yeah, so stem cells, like, again, correct me if I'm wrong, Dr. Baldauf. If you have like an osteoblast, right? It's like if you can get a stem cell to go to the area and become an osteoblast and grow new, that's the theory. The inflammation is like the biologics. Like if you can make something that decreases inflammation for there are many pathways. But that's what he's talking about as far as like inflammation. But even in just internal medicine, I mean, everything is inflammation. We're trying to do all this like low inflammatory diet and all this stuff. Yeah, I'm all about decreasing. Even like, I don't know, can you call stress inflammation of your soul?
I would agree.
It's like just decrease.
Are you married?
Yeah.
Yeah, there you go.
Inflammation.
Inflammation of the soul.
Well, Mike, you're big into meditation. Have you noticed that meditation helps with your health at all overall?
Well, I guess I'd ask these guys if I was healthy.
Yeah, you're healthier than when I met you.
Right.
That's easy.
I really use that. It quiets my mind because a lot of times there's so much going on between work and family and everything else that my brain just feels like it's always on. So meditation has really helped me to quiet the mind, which I would assume leads to health.
Can I ask you a question about that? When you first started with meditation, did you have a hard time doing it?
Yes.
Because I've heard that the harder it is to start, the more potential benefits you have from it.
I started, I believe, with, I remember the first one I did. It was something on YouTube that somebody recommended. I think it was 7 minutes. And now I do, every morning I do an hour. I use these CDs, Center Point. We've talked about that on the show, and it's all brainwave frequencies. And they actually use it at the Menninger Clinic in Cedars-Sinai. They put the patient on the meditation for, I think it's 8 weeks prior to surgery, and they were showing they were having better outcomes. So I don't know. Now it's kind of just a routine. So it's and sometimes I'll do an hour and a half if my brain's extra busy. So I think I just enjoy it now. It makes me feel good.
Is it clearing your mind? Is that what you're doing?
Quiets it down. Yeah. Then I feel more positive about the day. I think the way I see the world is a little more positive. It kind of gives you that positive mental attitude for the day.
So is it in the morning? Is it the start of the day you do it?
I do it at the start, and then I usually do maybe a half hour, 20 minutes before bed. But it doesn't, just meditating, it doesn't make you lose weight. I tried that.
Do you ever, like, let's just say it's a super complex case and like the ER is on you, the internist is on you, and you just finished up another really long case. Do you ever, like, before you get scrubbed in, do you ever like just sit and just go through like, okay, I'm gonna go through this case in my brain? Let's just say it takes an hour to do the case in real time. You're gonna just think about the case in your brain over like 5 minutes. Have you ever done that, or is that something surgeons do, or orthopedic surgeons do?
So it's interesting. When I first started, I was a general orthopedic surgeon.
Mm-hmm.
So all those things I mentioned earlier that we do. Mm-hmm. So if somebody didn't want to do it in the office, they would give it to me, and I'd just be like, yeah. And at the same time, like, I'm not sure I know how to do that. But I'm going. So those are stress cases. I used to call them pucker cases. And so you'd prep for them, and there'd be a certain thing, like maybe there's one nerve you're worried about, or there's one other aspect, and you're thinking about those, or you're thinking about your anatomy. I've been doing it so long now, and so much of it is routine, and some of the complexities that happen in surgery, I've seen that before, or something similar to, you know how to manage through it. So not so much now. When I first started, that happened a bit.
Okay.
But it's kind of segueing into something that I thought was kind of interesting, why I went into orthopedics, or not orthopedics, but in surgery. I can remember in medical school, so this is back in the 80s, and we didn't have cell phones, we didn't have computers, we didn't have a lot of these distractions, but we still had distractions. And I can remember being in surgery and all the things I had to do, whether I was thinking about a girlfriend or whether I was thinking about some project I had to do, I was thinking about, and this is just in med school, and I'm sitting there at a table with a patient on it, and I was just a med student, but I could do nothing other than what was right in front of me at that time. I couldn't answer a cell phone, not that we had them yet, but I couldn't really even think about anything else. I couldn't do anything else. I had to finish that task. I don't know if it's because everyone says they're ADHD, but I had to finish what I was doing, and I found that was my focus, that, hey, this is fantastic. I've got something. I can't walk out of the room unless I absolutely finish this. I can't leave the patient bleeding while I'm walking out of the room, right? So to me, that was a neat way of stepping into something, and that's where I got interested in surgery at that point, but didn't know that I wanted to do orthopedics at that point. But I thought that was just, thinking back, where the attention came from and focus came from.
It almost sounds like surgery was your form of meditation.
That's where, it's kind of where I was going with that. It was balancing me and focusing. It was kind of neat.
Yeah, there's definitely like that control, like the controlled environment, right? Like everything should progress according to plan in the OR. The temperature is always the same. Not that the procedure is always the same, but it's generally you're going to do the same kind of steps. And then hopefully like your scrub tech and your anesthesia guy, they're all, and that makes for a really great procedure.
It's funny you say that. So I'm all about that. I'm all about efficiency. So I've got extremely busy days, as many as 16 total joints in one day.
Wow.
With I'm doing them all. It's not, I don't have a fellow. I don't have someone else doing half of them for me. And the approach is I got some amazing people around me, and I can't do that without the OR staff that I have, the nurses, the techs, and we're dancing the whole time. It's basically not dancing the music, but dancing in the surgery, where I don't have to say anything to them. They know what's coming next. They know as well or better than I do the next step. It's going to be one of two things. They have both of the instruments ready for me. And so people say, how do you do things so efficiently? And I said, well, if you were just to bake a cake, but never had to look for any of the ingredients or flip the page in the recipe book or open a refrigerator door and everything, you just stood there and everything was boom, 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 boom. How quickly could you do it?
Yeah.
And that's exactly what it is. You just got an efficient team, and it's kind of neat.
And we were, Dr. Baldauf, he actually started and was part of the initial team at Henderson Hospital. Kind of had an opportunity to build a hospital from scratch.
Cool.
It was a mutual. The CEO invited me over to be chief of surgery, and I asked for some specific things that would help me in the OR, and he granted them, and it's been 9 years now. 9 years next month. It's 9 years.
So you operate mostly out of Henderson or all out of Henderson?
We've also have a surgery center that all of us are partners in,
Okay. Cool.
and a little bit different, but it's kind of unusual. I've got a very efficient system at the hospital, and that's usually backwards because I don't control the hospital staff.
Yeah.
But it's worked out to where I love the people I work with, and I've had a day on a Sunday where I was doing not an experimental surgery, but a different surgery, different type of knee replacement. I didn't want to do it in my main lineup, so I just brought 4 cases on a Sunday, and all 4 of my techs said, I'm there with you on a Sunday, on a day that they're off. It's pretty cool. So there's that kind of devotion and commitment. It's neat to see.
The fact that obviously all the people in the C-suite and you got together, they obviously saw the value and they put it in, and I'm sure they and you guys are all getting out the value. That's great. Yeah.
An interesting thing about orthopedic patients in the hospital, and I tell patients this all the time, especially when we're going through COVID, that whole pandemic situation, is they're not sick people going into the hospital. Mm-hmm. They're healthy people, or we wouldn't be taking them to surgery. Yeah. They just have a issue with one of their joints or what have you, but they're not sick. Now, if they get infected or something like that, or have some patients have some chronic diseases, but they're not a sick patient who we're trying to correct. They're a healthy patient. That's why a lot of them can leave the same day. Mm-hmm. But during that time period and currently, so we get people out of the hospital, and I tell them that. I said, you're not an unhealthy patient. You're a healthy patient. You've got a problem with one of your joints. I'm making that better. Get out of the hospital before you develop something that they have. And that's been a big promotion. So we saw that during the pandemic, where before that, we would commonly keep people in the hospital for a day or so. During COVID concerns, still had to take care of people, but we just sent them out even when people we wouldn't have sent out before, and everyone did better. So we learned during that time frame that just getting them back to their home environment, their home bacterial environment, their routines, they did better, and they didn't get sick. You don't develop those post-operative issues by sitting around. If you want to go get something out of the refrigerator, you get up and go out and get it out of the refrigerator. You don't press a button to have someone get it for you. People did better.
That's awesome. I'm all about, even though my specialty's hospital, I'm all about that. And so coming back to some of the ER folks, their perspective is we're rendering them a service by bringing them into the hospital, right? And that's fine if they need the service. But if they don't need the service, you and I have been in it long enough that somebody who doesn't need it comes in, gets too many sleeping pills, falls, cracks their hip, ortho's called, and then they go to the nursing home and they die from pneumonia, right? And they didn't even need to come in. So I'm all about...
Agreed.
And then you get the procedure. We have pain meds. We have, anticoagulation, which has been so great, right? Pain meds, anticoagulation, send them out. And then home health. Wait a second. There's also home health.
I appreciate both of you guys.
It's a big part of it.
Yeah, we've worked with Dr. Baldauf's patients on, post-operative total joints, total knees, total hips, total shoulders. And I was just remembering back where the patients would stay in the hospital for 3 days, 4 days. And there was even a period where the subacute or acute rehab was being used. They would go on over there for further physical therapy. And now sometimes they don't even stay overnight. It's been what an evolution.
So so you obviously love surgery, right? I mean, you obviously love orthopedic surgery. I've always said I like doing intubations and central lines and stuff, right? I don't love doing them at 3 a.m. That's just me. But with how much it takes a toll on you to do a procedure, and I know you love it, but there is a physical toll. How do you deal with that emotionally and physically, and then how do you keep yourself sharp in the 11th hour?
It's funny you say that. It all stems from just really enjoying what I do. So, I mean, as I'm sitting here, I got CMC arthropathy in my hand. I've got my own shoulder impingement. I've got to use my thumb to reduce a hip when I do a hip replacement, and it makes it difficult. I've torn both biceps tendon. Both of them, I did the same thing, the same time, the same day. I didn't miss a day of work, and that's doing joint replacement. So I tore my tendon on a Sunday, got my MRI right away. That following Wednesday, I did my full lineup of surgery. Did Tuesday and Wednesday of surgery, and I was the last patient in surgery on Wednesday in both cases. And then the following day, I went to clinic, and the day after that was the weekend. I would do surgery the next week. So it all stems from really enjoying what I do. But the part of the reason I enjoy what I do, I don't know if there's another field, and no offense.
Yeah, I get it.
But if you give somebody a medicine for their blood pressure, you just don't get that feeling where they come back and go, "Doc, I could not dance, and I danced in my daughter's wedding, and thank you so much." And they're crying, and out of tears of joy. There's nothing like that.
Yeah.
And I've seen it numerous times where it's a very life-changing event, and you just don't get that so much from changing somebody's blood pressure. Or, I mean, you're making huge changes in people's lives. Don't get me wrong, but you don't get that feedback like that. Yeah. So it's kind of a thrill, and kind of build on that. And then to answer you, I do some very long days, and I probably do more surgeries in one day of my type of surgery than just about anybody, even throughout the nation. And I had to build up to it. I can remember when I was at St. Rose Hospital, and I was like, wow, if I just could get 7 cases in a day, I could get 2 rooms, and then I could really, I can remember thinking I couldn't even get 7 cases at a time, and I've done as many as, I think, 17 in a day at this point.
Wow.
And yesterday I did 8 in 3 rooms, so I'll run 3 rooms at once. And the interesting thing about that, I do a lot of, 8 rooms used to get me tired, 8 cases used to get me tired. But what's funny is with 3 rooms, I'm the limiting factor. In 2 rooms, the hospital's the limiting factor, or the surgery center's the limiting factor. I'm waiting on them. But when there's 3 rooms, there's enough space in between where they're like, "Doc, get your butt in here." And so then it's a good way to be, because then they've got a little more time, and it's a little more efficient. They're at ease, and I'm doing what I like to do and just moving at a good pace. But it's just a matter of pacing myself, and I can't do 17 cases a day if they're an hour each, right? I just can't do it. So most of these are 25, 30 minutes for most of the things I do, and then it makes it easier. But it really helps to have really good people around. I've got a big staff, and they know what I'm doing. They help me, and they love to help me, and then I'm not doing all the stressful, straining stuff because they're so cooperative with the surgery, and a big part of it. I can't do it without them. So
cool. So you get through it because you love it.
Biggest part of it.
That's cool.
It helps to stay in shape.
Yeah.
But the funny thing is, it's kind of what keeps me in shape too, because I'm swinging hammers and saws and chisels, and so even when I have my biceps tendon, I would have someone hold the leg, or I'd lift it, or I'd put my hand on the drill, and I'd have them hold the drill for me and stuff. But they were just cooperative. But I think it helps to be in shape.
Talking about staying in shape, something you both have in common is you're both very fanatical about fasting.
Yeah. Do you intermittent fast?
It's apparently working better for you than for me. But
No, I'm all about fasting. In fact, as like I'm not doing the surgeries, right? But I would theorize, because that's what internists do. We like to be very theoretical. Is I would theorize that you could. Do you drink coffee?
Too much, probably.
My thing is coffee. Like I can't fast without coffee, so I have coffee with cream. That's my thing. But like I could imagine if I was doing ortho surgery, I could have coffee, fast, and I don't know about 17 cases, but let's just say 5 cases. And I think that if I fasted, I think I could probably be more on point with those surgeries.
Absolutely.
And I feel like there's a point, and you could never experiment with this because the patient's life is in the balance. But if you could experiment with it, I wonder if like in your 11th or maybe your 10th hour of not eating, I wonder if like everything would just like slow down like the Matrix. Like you're just so
in the groove.
Yeah. Like everything just, sorry about this. But I wonder if everything would just like slow down so that it's not slowing down in real time. You're not becoming slower. You're becoming faster, but everything else is
Perception.
Slow. Yes.
It's funny you say it though. I have done fasting where I fasted through the day of surgery.
Oh, cool.
And you probably know as well that your mental acuteness is enhanced when you're fasting. So you don't get that postprandial somnolence, right? When you're eating lunch and you get sleepy, it doesn't happen.
Yeah.
You just, like you're saying, staying on it and it keeps you alert. I agree with you on that.
We actually got Mike into fasting, right?
We did a fasting challenge with me, and I've always looked up to you both because you do the fasting so easy. And I've yet to get a day. I don't know how you get past that 12th hour. I think I did multiple days, but 12 hours I think was the
Well,
challenge.
you got a 14-hour day once, didn't you?
Maybe I got a 14-hour day.
And did you feel any different from the 12-hour days?
I did, and I also felt a lot more energy that following day when I was at the gym and I was just energized. That I could notice that. Now I think you both, and I've said this to you, is you have God working through you, right? You're taking care of people, so I think that puts you on a different level for fasting.
I think the
connection to God.
We talk a lot about God on this show, if you can imagine. Crazy. No God, no politics, no religion, no politics, but we always come back to it. But I think for you, probably early on in your career, there was no choice. You probably were doing intermittent fasting before it even became on vogue, right?
Well, I was actually the opposite of that. So when I was at Tulane, I was in general surgery for 2 years before I went in orthopedics. And they prided themselves on divorce rate and just working people like nobody's business. And I would do, no joke, when I was going through residency, it was 24 hours on, and then you had to do clinic the next day. So you could be on 36 hours, have 12 hours off where you did that all over again.
Yeah.
And you would fall asleep at stoplights. You couldn't make it home. You're just sleepy all the time. It was just brutal. So they wouldn't let you eat. So I would be like, no, I'm just going to the bathroom. But I would run down the cafeteria and just hog down burgers and whatever so fast. And no, I was just in the restaurant because I couldn't take it. So I was, the opposite of fasting then.
Yeah.
But no, I just evolved into it. And it just, I wanted to ask you, there's some studies that show that if you can maintain a 7-day fasting, that may be anti-cancer. Is that true? Is there any validity to that?
You know, we're talking about stem cells. There is a certain, I think it's, you can definitely get there in 7 days. But even like a 72-hour fast, they say is like a stem cell trigger. So if you have, we could even apply it to ortho. Like if you have something, I'm not talking about a fracture or a tendon total tear by any means, but like something small, if you have a stem cell trigger, then it'll trigger stem cells to go to that area. Or if you have cancer, you could have stem cells go to that area. So yeah, I am a big believer in cancer treatment and fasting. In fact, there are some chemotherapy regimens, even right now, where they do the chemo and they add fasting onto it. And it's not like they're doing it all willy-nilly. they're actually comparing it to doing whatever it is, whatever chemotherapy agents by itself compared to the chemotherapy agents plus fasting, and these guys always do better.
Really?
Yeah, man. There's something about it. It's funny you mentioned because I know you're about 10 years ahead of me, but there's the same thing when I was thinking about applying to all these surgical subspecialties. Same thing. It was like a badge of honor.
Yeah.
To be like, oh yeah, like I've been at this for 20 years and I'm on my 15th wife, and it's just like, yeah, but that sucks. Like that actually kind of sucks. So then like neurosurgery, the big dichotomy, I don't know if you remember, was like dermatology and neurosurgery, right? Like, well, I mean, not to offend any of the dermatologists. I have a great friend who's a dermatologist, but like one is more exciting than the other, right? Like without a doubt. The thing is that if you go into this, you may not have a life, right? Or you need to figure out a way to get a life, But yeah, I remember it was a badge of honor. And like at the end, like we were talking about family, right? At the end of, have you seen The Godfather? We talked about The Godfather, right? At the end, right? I don't want to spoil too much of it for do any of our guys watch The Godfather? Do you think any of our viewers know who The Godfather is? Maybe.
I would think the 40-year-olds.
Too much of a classic not to.
That's true. So like at the end, this guy who had all this power, all this money, right? His children hate him, and he just gets assassinated by some low-level person. And so for me, what I took from that was you can get to the end of your life, and if you're not surrounded by family who loves you, so what, right? Or have you guys seen this? I told Trevor about this. Have you? I don't know if you would, but you might remember. Do you remember Die Hard?
Oh yeah.
Oh, love that movie. Okay, I was pretty young when it came out, but my brother snuck me in to see it, and so like I loved Die Hard. Okay, and so what's funny is my son, who's 7, I watched Die Hard. I mean, my wife didn't love it because there's a lot of swearing and all this other stuff, but like we watched it. And there's that one part, like my son is so into it. There's this part where he says, "Yippee-ki-yay, motherfucker." Okay, and so my son starts saying all this, and my wife doesn't love that, but whatever. So we're watching this, and then the reason why I watched that is because I love the movie. I think it's one of the most awesome Christmas movies. And then we watched this new special on Bruce Willis and his frontotemporal dementia. So here's this guy who has this frontotemporal dementia. He doesn't even know that he's Bruce Willis. He doesn't even know that he's famous. You see what I'm saying? But and that's very sad, very sad. But all he knows is that there are people out there that love him, right? Like his not the one who is an actor, but another lady is his wife, and he's got these kids. He might not recognize them, and that I don't know that I would want to live like that, but at least he knows that someone loves him, right? So how he's got all this fame, and what I was trying to teach my son is like it's not really all about all the money and the fame and all that other crap. It's like, who loves you? Who do you love? Or how much love can you put out there? I'm sounding super hippie right now. How much love can you put out there, and how much can you?
Did you ever hear of the book Die With Zero?
No. Is that like about minimalism?
Sort of. So it's I think it's Bill Robertson, if I got that right. It's a commodities trader.
Okay.
His theory is if you die with $100,000 in your bank account, you worked $100,000 too hard.
Oh, I love that.
And it goes through a lot of different things. Like there's certain moments in your life where you can no longer, if you don't do that at that point, you can no longer do it again. And one of the examples is he had a roommate, and his roommate decided to go backpacking through Europe. He's about the same age as me, so you could do it back then, right? He's backpacking through Europe without a cell phone and all this, and he didn't take his roommate up on that offer. Well, now it's 20 years down the road. He cannot physically do that now. He can't go backpacking, not with his current situation, with his money and his job and his time and his all the different aspects, his family, what have you. Can't do it. So that moment passed. There's certain things in life that you have to take the opportunity to do it, or you cannot experience that in the future. And
So true.
And there's other aspects of it, like don't wait until you die to have your children inherit your income, because they'll already be typically in their 80s, they're in their 60s, they've already made their life path. You're giving them money, and they're like, okay, thanks, Dad. I mean,
Yeah.
but
Doesn't really move the needle.
But you give it to them between the age of 25 and 35 when they're trying to build that, and just give it to them with no restrictions. And this is, you do what you need to with this. For instance, I just gave my kids a service work truck for their job just a couple months ago in July. Here, this is for you. And it makes a bigger impact at those moments in their life than it does when. But it's a really interesting book.
I love that. I really like, and we were talking about like enjoying stuff as it happens. My father passed away a couple of years ago, and what everybody else will see, because I'm not an orthopod, I've never had a Ferrari, but but basically, what people will see as a midlife crisis for me, like if I get a Ferrari, is just because my dad, he liked cars, and he was like 85 when he passed away. He never sat in one, never drove one, and it's just like, even if he was alive right now, I don't know that he could. So I got to do it while I can. But everybody out there is going to be like, oh, there's Dr. Ali, he's got a Ferrari, you know? And it's going to be like, oh, he's going through his midlife crisis, right on schedule.
Is that a Mike and the Doc Ferrari?
Oh, yeah, I think so.
Wrapped.
I'll put this on the side. Put this on the side.
It's got a good look to it.
You can just review it on the channel and use it as a business write-off.
There you go. Yeah. Yellow. Okay, hey, Doc. So where do you see the future of orthopedics in the next 20 years?
I'll be gone.
I was gonna say without me in it, but I know that you're doing your job. So
the Dr. Baldauf robot.
I've got a funny comment on it, where joint replacements last about 30 years right now, give or take, depending. But I tend to get a little bit jocular with my patients sometimes, and I'll tell them, well, I mean, I think I'm retiring in 7 years. It really only has to last 8 years as far as I'm concerned. But there were some comments about, will you still need joint replacements? Will you need some of the interventions you have now? It's hard to predict where all this is going. It's funny. I've been in it for a long time, and you think there's these huge advancements, and there are, but when I look back on it, they're not as huge. They're not as big at jumps as you might think. They're very incremental. It's just a culmination of a bunch of small jumps to get where we are. Some of the advancements are incredible now. Like joint replacements used to last 12, 15 years, and it was just a simple, well, it's not simple at all, but it's a change in the plastic that goes into joint replacements that made a huge difference for why joint replacements last way longer than they used to. And there's things like that that'll happen. But I think we're always going to need orthopedics. There's injuries that happen. There's things that break. There's parts that wear out. And where things may change is if they can find a way to keep the progression of arthritis or find an early treatment to where it doesn't progress. But you'll get it from trauma. People play sports. People do things. Things happen. Car accidents happen. But the technology I've seen, there's so many neat things that have happened. Just switching from stainless steel to titanium makes a huge difference, and has made a huge difference. Switching some of the design of implants, but a lot of the stuff right now is pretty dialed in. If you can do an artificial joint and it lasts 30 years, that's an incredible amount of time. And by the way, the youngest joint replacement I've done so far for a hip is 15 years old.
Wow.
And he was in the Philippines, broke his hip, and I'm thinking this thing's got to last 70 years for this guy. It won't, but it can last long enough and switch part of it out in 30-some years and get more of it. Prior to that, there was an individual I'd taken care of who'd both hips and both shoulders died from avascular necrosis.
Oh.
It's not the way you think of it dying, but the bone basically necroses because it gets lack of blood supply and the bone does die. So I replaced both hips, both shoulders, and he was 19 and he's currently 42 or 43 years old, and he's been playing softball with his kids and working a regular job where he could hardly move before. So the advancements I've seen have been incredible, It's hard to predict where some of this is going to go, but hopefully some of it is, people dread surgery. And it'd be nice to be able to do some of the stuff we do without surgery. I'm sure a lot of this is trying to go injectables, some of the biologics we talked about, being able to draw out pain relief before someone needs surgery for longer periods of time, things like that.
You mentioned something about maybe not, there's talks of not needing to do joint replacements in the future. What type of medical advancements do you think would need to happen in order to make that a reality?
It's hard to, I mean, it's what I said earlier is incremental, and it's getting there. It's not going to happen in a big jump. It's going to happen incrementally. Some of the biologics, some of the injectables, it's not always, it's not the surgeons per se, it's the people behind the microscopes that do a lot of this, right? And then we apply it in the real world and see what happens. So it's a lot of the research that's making a difference. And don't get me wrong, there's a lot of orthopedic surgeons that are really into research and very good at their research and also excellent surgeons. Mm-hmm. But it's just going to be incremental. And I think what I was trying to say with my last comment is, looking back, some of the things, if I look over 30 years and look at it quickly, it seems like there's some big jumps. But, man, it was slow climbing up that hill over those last 30 years. And, hey, this is pretty neat what they're doing here. And we made a mistake there, so we got to take a step back and we got to go a different direction. But we're still climbing up that hill, and it's neat to see the differences. But I think that potential's there. I'd like to see the ability to stave off some of the destructive effects of post-traumatic arthritis or just osteoarthritic changes. And it's going to be a long time coming, though.
You know, it's crazy. We have you now, right? So I run a lot for me anyway. This is the most I've ever run. Is there a correlation between, like, we're talking about wear and tear, right? And I know there's like weight-based exercise, right? Mm-hmm. But I want to run forever. But my knees, like somebody who runs a lot, like, is there a correlation between, I'm just going to ask, is there a correlation between running and the guys needing knee replacements down the line?
Yeah, I mean, if you look at the spectrum, mm-hmm. people who are in athletics, same thing. But is it more stressful to be running 3 times a week, or is it more stressful to be carrying an extra 150 pounds every day?
Oh, cool. Right. From being, yeah.
So there's different traumatic events. The funniest thing about runners, of all the athletes I see, runners have, it's a different mindset. Mm-hmm. So say someone is a cyclist, and I'm a cyclist, and mm-hmm. someone can't do it for a while. They tend to be able to adapt a little bit better. Runners cannot. Yeah. Nothing gives them a high like running does. It's true. Cycling just isn't running. Nothing else. Swimming just isn't like running. Yeah. It's funny, and so they're more dialed in with it. Running is like a meditation we're talking about. That's really a big part of it, yeah. And it's an addiction.
Yeah. So that's very true. But like, even with the addiction, right? Should I
keep doing it?
Keep doing it. Okay, good. Okay.
I always tell people.
I was hoping you'd say that.
I always tell people you got to do what you. I mean, we don't know how long we're here. I don't know if I'm going to walk out of this and the satellite's going to fall on my head. Right.
Right.
We don't know what's going to happen. So do what you
love.
You know, if it's legal. In some cases, I guess if it's not, but.
The endorphin rush after a really long run for me shouldn't be legal.
Because that's that thing we talked about before. You don't know if you can run when you're 80.
Right.
So do it now.
True. That's very true.
Don't miss the opportunity.
All right, guys, before we sign off, just Dr. Baldauf, something to leave the audience with. If you could give people one piece of advice to avoid ending up in your office for joint or bone issues, what would it be?
Staying active. And so to avoid being in an orthopedic surgeon's office, just being aware of your body, staying active. I see more problems from people who are inactive or not aware. I mean, I see a lot of injuries from simple things like I can probably 3 times a week I'll see a dog-related injury. Stepped over a dog gate, fell, stepped on a dog toy. Dog ran between her legs, the leash caught something. It's being aware, and I'm a dog guy, so I'm not discounting that. But things happen, and some things you can't avoid. But I got to tell you, as a society, and I'm probably part of that, is that weight gain is probably the biggest issue that is affecting us and hugely affects the joints. And there's a whole lot of money in medicine that's going into medicine because of the obesity. It just is. There's a gentleman I saw, Samoan guy years ago, awesome guy, but he had an extra 160 pounds on him, and he had horrible knees. And I would have operated on him in a heartbeat, except he was so big, he was a surgical risk. And I said, you know what, you just need to lose some weight, not just. He had to lose a lot of weight. And there's no way he's going to do it. Dang, if he didn't come back, I think it was a year and a half later, didn't he look like the same man? He'd lost 160 pounds. His knees looked just as bad, if not worse, on x-ray. Doc, they don't hurt at all.
Wow.
And
Wow.
I think that's probably the biggest thing that can happen is if people watch. I think we're set up as a culture. We don't eat appropriately, and we need to change with fasting we were talking about earlier. I don't think as a species we're designed to be eating 3 times a day. I don't think they had a fast food joint sitting there. So I think that we've developed, probably for financial reasons, into poor eating habits, and I think if we could change that, it'd make a huge difference for a lot of people.
Dr. Baldauf, again, you've been very influential in my life, and very grateful to have you on the show today. Thank you for being here.
Thank you. It's mutual. You've been an excellent friend through the years and learned a lot from you as well, so thank you.
Thanks, Dr. Baldauf. Much obliged. Thank you for all your excellent advice.
Pleasure meeting you as well. Thank you.
All right, Doc, thanks for joining us on this episode today. For anybody that's watching, don't forget to like, comment, and subscribe. Stay tuned for the next episode, and we'll see you in the next one.